Welcome back to Family Planning and Abortion for Medical Students. In the last two videos, we discussed methods of temporary and permanent contraception as well as their levels of effectiveness, side effects, and more. Now we will be discussing barriers people face in accessing effective contraception as well as abortion services when contraception fails. We will be discussing the following APGO learning objective regarding barriers to effective contraception use. Our learning objectives today will be to understand the types of barriers to contraception access as well as recommendations to improve access from ACOG and understanding the relationship between contraceptive access, unintended pregnancy, and abortion. For the rest of this video, I will be covering a 2015 ACOG article about barriers and recommendations for improving access to contraception. They found the following major causes of barriers to contraceptive access. These were knowledge-based, legal and legislative climate, cost and insurance, unnecessary medical practices, institutional and payment-based, and inequities. First, we will talk about knowledge deficits. ACOG noted that abstinence-only sexual and reproductive health education in schools has not been effective in decreasing risky sexual behavior or increasing the age of first sexual encounter in adolescents, whereas data measuring schools that use comprehensive sexuality education have been shown to achieve those desired outcomes. This lack of comprehensive education is also to blame for many misconceptions held by the general public regarding certain birth control methods, such as higher risk, health complications, or infection rates higher than are actually present. Many people also believe that certain types of contraception can cause abortion, when in reality, none of the FDA-approved methods of contraception do so, indicating a large misunderstanding about the mechanism of action of many forms of contraception. Unfortunately, the general public are not the only population with knowledge gaps in this area. For example, many healthcare providers do not have a clear understanding about the risks and benefits of IUDs, and do not have a full understanding of how to counsel patients in contraceptive methods based on their medical histories and considering contraindications for individual patients. The ACOG recommendation for this barrier is to increase comprehensive sexual health education in schools and for the general public, as well as ensuring that physicians address their own knowledge gaps in methods of contraception. The next barrier includes the restrictive legal and legislative climate that currently exists in our country surrounding contraception. A large area of restriction involves minors. Almost half of states in some way restrict the ability of minors to consent to contraceptive services. There are also proponents of conferring the legal status of personhood within our reproductive health laws as beginning with a fertilized egg. If this measure was implemented, anti-abortion proponents may assert that methods of birth control that prevent implantation of fertilized eggs, such as hormonal and IUD forms of birth control, would be forms of abortifacients and made illegal. The ACOG recommendation for this barrier includes removal of parental notification and consent for contraceptive services and confidentiality for minors seeking birth control. ACOG did not specifically address the very polarizing topic of personhood in their recommendations, as this ties to the discussion of induced abortion, which is a nuanced topic that we will discuss in later videos. Cost and insurance are huge barriers to contraception access. ACOG found that even when insurance companies did cover contraception, patients still pay about 60% of the cost out of pocket compared to the typical 33% out of pocket for non-contraceptive drugs. Another issue is that employers may opt out to be exempt from providing contraception under the Affordable Care Act for their employees based on religious or moral beliefs. This right was upheld recently in a 2020 Supreme Court ruling. In addition to employers, pharmacies and pharmacists themselves can limit access to contraception by refusing to keep them in stock, and individual pharmacists can refuse to provide emergency contraception based on personal beliefs, forcing patients to look elsewhere for these products. Another issue is that insurance plans prevent over 70% of patients from receiving more than a 1-month supply of contraception at a time, and even then will not always allow patients to obtain timely refills. ACOG recommends that the Affordable Care Act cover patients seeking contraception regardless of employer beliefs, increase funding for underinsured patients to get effective contraception, eliminate the disproportionate out-of-pocket costs for contraception, and make it easier for patients to obtain several months of contraceptive supplies at a time. The next barrier includes unnecessary medical practices. Some insurance companies require patients to fail certain contraceptives before initiating more expensive options. For example, trying combined oral contraceptive pills and not tolerating them before getting a LARC method, instead of considering patient preference and efficacy. Other unnecessary practices that discourage patients from initiating contraception includes procedures such as a pelvic exam or cervical cytology, neither of which are medically necessary before starting a new birth control method. Another common practice that can deter patients is the requirement of 2 medical visits for initiation of LARC methods, one for consultation and another for placement. This is not necessary and can be discouraging for younger patients or patients who cannot afford the time and cost of 2 provider appointments in close proximity. ACOG recommends the removal and minimization of the practices and policies that support these unnecessary measures, as they are not beneficial and can even be detrimental to patients. Institutional and payment barriers are another source of problems for those seeking contraceptive services. LARC methods particularly tend to have high upfront costs without the support systems in place to help low-income patients afford this efficacious form of contraception. Although many women desire to undergo permanent sterilization or other long-term contraceptives after they've completed childbearing, this often cannot happen due to lack of OR space, lack of coordination between care team members, and misplaced or incomplete consent forms. This is problematic because postpartum and post-abortion are extremely convenient and advantageous times for the patient, as we discussed in the last video, and studies have found that almost half of patients that did not receive a requested postpartum sterilization procedure were pregnant again within 1 year. LARCs and other methods of contraception are also not always started, especially post-abortion, due to low or lack of reimbursement because of differing funding sources for abortion-related and contraceptive-related procedures. Another institutional barrier, which can sometimes be an individual barrier depending on the provider, is the underutilization of LARC methods, particularly in adolescents and nulliparous women. While LARC methods are first line for these populations, some providers and institutions do not support these methods in all applicable populations due to misinformation, as mentioned earlier, or unsupportive institutional practices. ACOG recommends adequate Title X funding and expansion of Medicaid to help patients pay for effective birth control, adequate compensation for contraceptive services, and the implementation of policies and reimbursement for immediate postpartum and post-abortion LARC placement and sterilization procedures. Health inequities are a huge issue in medicine in general, and reproductive health and contraception access are not exceptions. Minority and low-income patients have higher rates of adverse reproductive health outcomes, are less likely to be using effective or any contraception, and have a 5 times higher unintended pregnancy rate, probably as a result of being more likely to be uninsured or underinsured, as well as due to underlying provider biases. The ACOG recommendation at the time was to increase funding for research to identify strategies to reduce these health inequities in contraception access. This research into health inequities is absolutely needed in the field of reproductive health, as well as pretty much every other area of medicine as well. That was a lot of information, but it's really important to understand some of the extrinsic factors that play a role in why people are not able to access contraception and how that can lead to higher rates of unintended pregnancy. This will help ground our next discussion of the epidemiology of unintended pregnancy and abortion rates. Thanks for listening.